Good afternoon, everyone. I hope you're all safe where you are, given the recent inclement weather and flooding and all those things that accompany it. I am Dr. Gregory Boyce. This is our 78th, I apologize, session of MRF HIV STI Echo. With me today is our subject matter expert, Dr. Jeff Edwards, Abigail, who's here as well, and Conrad, who from IT helps coordinate these events. So today I thought I would just do a very quick summary of some of these sort of studies that were highlighted at the recently concluded IES 2022 in Montreal, because I think we're at a strange inflection point in HIV management right now, given, I can't even say dual pandemics, the triple pandemics happening at the same time. Monkeypox thankfully seems to be dying down a little bit, but it's still a matter of issue of relevance. And it does impact total resource allocation and movement around the globe, and how it affects personally with HIV as well. So I'll just start up the presentation. Again, we're going to be fairly brief today. And we have another case that we'd like to discuss that will follow the presentation. Ms. Cruikshank is here. All right, everyone. I hope you can see the screen as soon as I start to share. Give me a second. Welcome, Maria. Good to see you after a long while.
Thank you so much. It's good to be here.
All right, is everyone seeing?
Yes, we can.
Yes.
Okay. So just a brief overview of some of the studies in IES. Again, we acknowledge the support of ITEC and HRSA, who are funding the support for this program. I have no disclosures, and essentially what we hope to learn, we will just discuss some of the data presented at the IES 2022 conference. The actual abstract book is about 1,500 pages, so it's a really rich conference, and unfortunately we won't able to attend this year. Hopefully we shall be soon. Actually, one of our abstracts was accepted. So as usual with these conferences, we usually have a presentation from WHO/UNAIDS about where we are at this point in the evolution of the pandemic over time. And their slogan was "in danger," right? The 2022 UNAIDS global updates. And when they say in danger, what do we mean? So in terms of what our targets were, remember we transitioned from 90 in 2020 to 95 by 2030 in order to achieve epidemic control. And one of our goals, our global goals, would have been 500,000 or fewer new infections in 2020, 200,000 or fewer by 2030. But in 2021, there were 1.5 million new infections, which is over 3 times where we should have been last year, right? So it is difficult, I think, for us to envisage how we're going to get 200,000 or less in the next 7 to 8 years. It does require a serious redoubling of efforts, a reimagining of how we deliver all aspects of care all along the cascade, whether it's prevention, engagement in care, monitoring, evaluation, outreach to key populations, differentiated service delivery, all those different things that come together to deliver a package of care to persons with HIV, both to keep persons in care and to prevent new infections. And one of the things that is driving both deaths from persons with HIV as well as transmissions, because persons with higher viral loads transmit, are people who are diagnosed late in the course of their infection. I remember some years ago we did a study with 2014, 2015. And in terms of late presentation, meaning presentation with CD4 counts less than 200, meaning an AIDS diagnosis at presentation, at MRF it was 40%, about 5% years ago. I believe it's lower now, I have to check those figures. But in certain parts of the world, and this study was presented for Africa, it can range anywhere from 29 to 30 in places like Uganda and Cameroon, all the way up to 45% in Tanzania, and then 53%, meaning more than half of everyone presenting with HIV is presenting in Zimbabwe with an AIDS diagnosis. And what are the drivers for this? Well, we saw the same sort of thing in Trinidad, that it was mostly men presenting with it, and I think data was showing there was a 2-to-1 risk of male presenting with a CD4 less than 200. And that has to do with how men seek healthcare. So we don't tend to go to the doctor unless we're sick. We try all sorts of things before we go to the doctor. So we have a back pain, we'll try this, we'll try that, we'll try pull this, we'll try that, then we'll crack it before we go to check to maybe check to the doctor to realize it's prostate cancer. Right? And it's the same sort of thing with health-seeking behavior when it comes to HIV. If you feel well, you don't go to the doctor until you start to lose weight, in which case something's going on. Right? There's also a failure to test because you don't recognize your risk sometimes, or the fear of stigmatization. All individuals do not perceive themselves to be at risk, so that's one of the things we're seeing as well. Separate and apart from persons with HIV getting older, persons who are older are being diagnosed with HIV. And in certain cultures, the healthcare decisions are made sometimes by the female for the male. So the females who are in more contact with the healthcare system might decide, look, husband, come, I go to the health center, come with me. Husband, you don't look well, you need to go to see the doctor. Right? And that in and of itself can delay individual access to healthcare. So in terms of how we go about dealing with some of these things, PrEP around the world has become an important tool in terms of prevention of HIV transmission, especially in persons who are demonstrating at-risk behavior. We recently did a trainer session in Trinidad with persons in the region. Mrftt participated, as well as some other non-governmental organizations and civil society organizations, in terms of training persons to deliver PrEP training, which is modeled after a 3-month cycle. So you get pre-exposure prophylaxis today, you come back in 3 months, get an HIV test and a prescription and so forth. But there has been a conversation about demedicalizing PrEP, because some of the populations that we would like to interface with the most and offer pre-exposure prophylaxis are precisely those populations who will not come every 3 months, who will not want to come to see a doctor every 3 months, walk into an office and have to spend time off in the day to go through this process. So there was a pilot study done in Kenya where, rather than a 3-month cycle, the cycle was extended to 6 months. So you would, the person receiving PrEP would actually see a doctor every 6 months for testing, but in between the 3 months would do a HIV self-test, whether saliva-based or blood-based, and report that back. There would also be potential opportunity in some parts of the world where they're a better resource. You can self-swab, whether it is rectal swab or throat swab or even vaginal swab, right? I can send those in as well to screen for STIs. So essentially what the outcomes of this study was how many persons would have an HIV test at 6 months, a PrEP refill at 6 months. They would check to see what their PrEP adherence was, as evidenced by tenofovir drug levels. And actually, when they did this study, the outcomes were quite good. So in terms of a comparison between the standard of care, which is see a doctor every 3 months and get testing every 3 months, self-testing at 3 months and then seeing a doctor at 6 months was essentially identical to standard of care. And in some cases, in terms of PrEP adherence, actually was slightly better. That might have to do with ownership of your care. That if you're the one making decisions, you're the one investing the time to make sure you get these things done, you might actually be more motivated to adhere to pre-exposure prophylaxis. Now, in addition, because there was a thinking in Kenya at the time that single women would be a population that might not want to access PrEP because of issues around intimate partner violence and gender, and the fact that you're taking HIV pill means you have HIV and what that means. And this study and this protocol might actually encourage women to participate. What they found is actually exactly that the performance was as good as standard of care, and actually in terms of adherence was superior to standard of care. And again, this would have to do with ownership and privacy and all these other things. One of the exciting things that came out in terms of prevention was not just only prevention of HIV, prevention of bacterial STIs, because we understand the link between STIs like syphilis, gonorrhea, chlamydia, and HIV transmission, both from a behavioral aspect, that persons who tend to acquire bacterial STIs frequently are by definition engaging in risky sex practices, as well as from the biological part of it, that if you have a bacterial STI because of inflammation or microtears in the genital or even rectal line, that you might be more prone to HIV acquisition. That there was this study to do doxycycline post-exposure prophylaxis. So, for example, what that would mean among men of sex with men or transgender women who were either HIV positive or HIV negative on receiving PrEP, that after a condomless sex act, that they would take a start dose of 20 milligrams of doxycycline. Almost, if you think about it, like a morning after pill, but maybe 2 morning after capsules, with the idea that it would prevent acquisition of one of these diseases, syphilis, gonorrhea, or chlamydia. So they actually randomized men of sex with men and transgender women who were positive to doxycycline or placebo, or persons who were receiving PrEP to doxycycline or placebo. And the primary endpoint would have been actually what was the rate at which STIs occurred, bacterial STIs, in the control groups as opposed to intervention groups during quarterly HIV testing. And so in terms of baseline characteristics, they were fairly similar among groups. As you can see, there was quite a lot of bacterial STIs in both groups. And in terms of what the endpoints were, so in terms of the STI incidence per quarter, you can see standard of care was about 31.9%, and the doxycycline group that dropped 10%. So that's a significant decrease. And similarly, in the PrEP cohorts, or any person living with HIV, remember that's both men of sex, men and transgender women, it was similar, 30.5% versus 11.8%. So, 45% risk reduction in gonorrhea, less marked, but still significant, 12% reduction in chlamydia and 30% reduction in syphilis. Now, in terms of the risk of resistance, because that would be one of the things we would worry about, that there would be new resistance arising because you have persons being exposed to single doses of doxycycline. There was a certain amount of resistance uncovered, but actually what they believe this to have been was pre-existing resistance to gonorrhea. Pre-existing gonorrhea resistance to tetracycline in general and doxycycline in particular, as opposed to new resistance being developed as a result of the intervention. And that was comforting, because there was a concern that any intervention like this would actually drive increasing doxycycline resistance among gonorrhea isolates, and that could cause gonorrhea, which is already, as Dr. Edwards would have said in some of his lectures, already becoming a superbug. The last thing you want is widespread adoption of a procedure that worsens that progression, that development. And additionally, in terms of safety, there were no grade 3, which is moderate to severe adverse events, and discontinuation rate was low. So I'm going to talk a little bit now about HIV treatment in terms of our transition as ongoing and stalled to dolutegravir. Remember, we would have transitioned dolutegravir in January of this year. We've had to pause on putting new patients on dolutegravir, unfortunately, for a short period of time. But there was some studies that were done in terms of transitioning from based regimens, which is kind of where we were for many years, to dolutegravir-based regimens. And one of those studies, something called NAMSAL, was done in Cameroon, which was a study conducted randomizing naive persons who are ARV naive, meaning never on treatment, to two regimens. Essentially, low dose efavirenz, which is like a triple with a slightly lower dose, or lamivudine tenofovir dolutegravir, which is TLD, which is what we had started in January. And essentially, they were trying to document that the dolutegravir arm was at least equivalent to the efavirenz arm, which was standard care at the time. And the data that is presented actually describes up to week 192 of safety and efficacy data of the dolutegravir arm of the intervention. And the virologic response essentially showed that there was at least non-inferiority, or in some suggestions, superiority of the dolutegravir arm in terms of virologic suppression in persons, especially in persons with higher viral loads. What they found was in persons with viral loads above 100,000, efavirenz did not perform as well in terms of virologic suppression. Right? So 64% versus 87% in dolutegravir. 64% in efavirenz arm versus 87% in dolutegravir arm. Right? And there was evidence of faster virologic suppression by dolutegravir, which we sort of knew, which is one of the selling points. And there was more virologic suppression among persons, less virologic suppression among persons who were randomized to the efavirenz arm with a baseline viral loads under 100,000 as compared to the dolutegravir arm. But what I think we was of ongoing conversation, and I'll come to this a little bit later with another study, was that the question around weight gain and integrase inhibitors, especially in this setting. So what they found was that at week 192, they would have found a weight increase of 7 kilograms in the dolutegravir arm versus 5 kilograms in the efavirenz arm, which was thought to be significant. And the reason why that's important, and again, it may be expressed in later research, is that as we sort of pivot some of our understanding of how we manage HIV from a pure HIV standpoint to management of non-communicable disease standpoint, because our patients are aging and developing NCDs, weight gain is going to become important in terms of a signal towards development of metabolic syndrome, a signal towards development of insulin, hypertension, and all the complications of overweight and obesity. It was, however, thought that, and this is coming current thinking, and it will have been evidenced by some other studies, that the reason for weight increase is not so much dolutegravir driving weight gain, but that, especially in persons who have a certain polymorphism, that efavirenz actually promotes either slower weight gain or actual lack of weight gain, because it can affect some serotonin receptors in the brain and actually cause reductions in appetite and not exactly weight loss, but a failure of normal weight gain over time. I will come to that in a little more detail in the next study. So essentially, the conclusion would be that both dolutegravir, dolutegravir, and efavirenz dolutegravir is not very effective and safe for treatment of naive persons with HIV. There were better rates of virologic suppression with dolutegravir versus efavirenz, especially those with high viral loads. But the virologic suppression was less durable for patients with higher viral loads on efavirenz. I remember this is the 400 milligram reduced dose of efavirenz. And there was significantly more weight gain with dolutegravir, 3C tenofovir versus efavirenz, 3C dolutegravir, especially among women. Just going to pause the presentation just for a second. All right, thank you. So I just want to speak now about the advanced trial, which is done in South Africa, which is similar in terms of treatment-naive persons who are randomized to one of 3 arms. So emtricitabine to tenofovir efavirenz, which is what we've been using as around the world as first line for a long time. Emtricitabine to tenofovir dolutegravir, but tenofovir disoproxil, which is old tenofovir, and emtricitabine to tenofovir alafenamide and dolutegravir. It was over 192 weeks. And what they found was the dolutegravir containing arms in the intention to treat arms, the study had superior virologic suppression over efavirenz, but in terms of actual on treatment, those who remain in this study and remain adherent to treatment, there was similarity among the 3 arms in terms of virologic suppression. But again, one of the primary points of conversation was weight gain over time. So what was found was and especially in women, that women who were randomized to emtricitabine, TAF, tenofovir alafenamide, dolutegravir had the most weight gain. Emtricitabine, old tenofovir, quote unquote, and dolutegravir had an intermediate, and emtricitabine, tenofovir, efavirenz. I remember all 3 arms gained weight, just to highlight that point, but they had relatively the least amount of weight gain. And that was both in men and women, even though women had the most amount of weight gain. And again, the suggestion was, the thinking is that, again, tenofovir disoproxil fumarate, which is old tenofovir, the one we're accustomed to, has properties that actually militate against weight gain. Similarly, efavirenz has properties that militate against weight gain. So if you put somebody who was on a compound, a combination of drugs, that do not have those 2 elements, or one or the other of those 2 elements, you would find that, so for example, the persons who are on efavirenz and tenofovir disoproxil would have those 2 drugs keeping their weight under control to a certain extent, whereas someone who's on TAF and dolutegravir would not. So they would not have that suppressive effect on weight gain. I wanted to highlight 2 things about dolutegravir in particular. One, you would remember the SEPAMO study in Botswana, where they were following pregnant women who were exposed to dolutegravir either prior to pregnancy or during pregnancy. And initially there was a signal towards the increase in neurotube defects, but as time went on, what they found was that initial signal dissipated. And now, in terms of whether the person had dolutegravir at conception or later, whether they were on efavirenz or compared to persons who were not living with HIV, there was no difference in terms of birth defects, specifically neurotube defects, on mothers who were on dolutegravir and mothers who were not on dolutegravir. I remember we went through this some years ago with efavirenz, that for a while, about 10 years ago, when a woman became pregnant on efavirenz, we were panicking and had a scramble to get on something else because we thought efavirenz was FDA class D and was transgenic, and eventually the data actually showed otherwise. So I think this is the efavirenz experience and the dolutegravir experience, I think, are major teaching points in terms of how do we strike a balance between ensuring the safety of mothers who are living with HIV and safety of their unborn offspring versus ensuring that mothers who are women living with HIV and reproductive potential have equity of access to newer drugs. And I think this is a conversation that's going to be going on for a long time. And this is the second issue I want to talk about dolutegravir. In terms of the dosing of dolutegravir with tuberculosis, we have been advised based on pharmacokinetic data that you would get a significant drop in dolutegravir levels if someone is taking once daily dolutegravir and started on rifampicin for tuberculosis. But there was actually a study, an actual outcome study. The pharmacokinetic data is not there yet, or at least not yet reported. But in terms of actual virologic outcomes on once daily dolutegravir versus twice daily dolutegravir on a rifampicin-containing regimen, there is essentially no difference. As you can see, those lines are overlapping practically. And the rationale behind this was when as the abstract would have said, as little as 10 milligrams of dolutegravir actually is sufficient to achieve significant reductions in viremia in the those finding parts of the early development of dolutegravir. And in terms of the pharmacokinetic curves, the drug levels over time, in someone who is on 50 milligrams of dolutegravir exposed to TB drugs, rifampicin, versus 10 milligrams of dolutegravir, which we already know was able to produce significant viral suppression, they're a lot similar. So that was the rationale behind it. So it seems possible that we might be able to dose dolutegravir once daily with TB drug, which makes our life in Trinidad a lot easier because we don't have access to dolutegravir alone. So that we can dose escalate someone who is on TLD and who is diagnosed with tuberculosis. So if the pharmacokinetic data backs this up, it will actually make it a lot simpler in terms of how we treat patients who are on TLD and are diagnosed with tuberculosis. One other issue when it comes to another issue in terms of HIV cure. So a fourth patient was, at least for the last 14 months, seems to be cured of HIV. This is a 66-year-old Caucasian male described as a City of Hope patient. He was diagnosed with HIV, in 1988, which is quite a long time ago, over 50 years ago, with a lower CD4 less than 100. And he's been on suppressive treatment with undetectable viral loads for 30 plus years. In 2018, he developed leukemia, which is a chemotherapy followed by bone marrow transplantation from a donor with this CCR5-32 mutation, meaning that he essentially is missing the CCR5 receptor. He did continue treatment for 25 months post bone marrow transplant, but he would have stopped treatment and been off treatment for the last 14 months. And there's been no detectable HIV for the last 14 months. He has directly mounted. So he may be a fourth case. I remember all the cases like this that start off with the Berlin patient and everything else. COVID-19 is still a topic of discussion, and one of these things that was presented at the conference was this ongoing question that we've been trying to answer for a long time and have been having some difficulty answering for some time because of the confounders around how persons with COVID-19 and HIV, what the intersection is in terms of HIV influence on mortality and everything else like comorbidities, overweight, all that sort of thing. So there was, this data from the WHO from 50 countries who have submitted data from over 600,000 hospitalized individuals with HIV and who died with COVID-19, trying to see if there were patterns in mortality patterns in terms of the HIV status. And similar to what we've sort of found previously, there was a signal towards increased mortality with HIV and COVID-19, about 50% increase in hospital risk, tied primarily to CD4 less than 200 viral load over 1,000. So persons who are unsuppressed, virologically unsuppressed, with advanced immunosuppression. And this is the chart you see off to the left. And as the CD4s got higher, the viral loads got lower, the risk went through, but primarily driven by lower CD4 counts. And these studies were adjusted for comorbidities, age, gender, cancer, those sorts of things. I think the one concern would be, I don't know if there's BMI data here, one. And two, there's a significant number of persons who will be included here that are unvaccinated, because a lot of the data would have come from the African subcontinent. And the vaccination rates in a lot of the continent are low. So, for example, if you look at the graph to your right, with COVID-19 mortality by time by HIV status, you see that 2020 and 2022. Remember, 2020 was more alpha and beta. 2021 was, Delta came along the scene, and by 2022 we're talking Omicron. Omicron variant, which seems to have lower mortality, one, and two, the vaccination coverage would have increased over time, at least in South Africa. So 2020, 2021, not much difference in interestingly mortality, but by 2022 we start to see mortality drop in both HIV persons who are living with HIV, which is a blue bar, and persons who are HIV negative. And that will be the end of the presentation, and I'll just open the floor to any questions.
Hi, Dr. Boyce. Beautiful presentation. I just wanted to find out something in terms of the 66-year-old Caucasian guy. What was his sexual orientation? And in terms of the doxycycline with the PrEP, when you got the 11.8%, is there any kind of research on herpes and PrEP? Is there anything? Because I didn't hear anything about herpes. I heard about gonorrhea and I heard about syphilis, but I was just wondering in terms of a percentage.
So in terms of the patient, I believe it was MSM. And
okay.
In terms of the doxycycline, so it's not PrEP, right? What it is doxycycline post-exposure prophylaxis. So imagine so someone, for example, has a needle-stick injury, they would come to us for HIV post-exposure prophylaxis, and we give antiretroviral drugs to try to prevent that person from acquiring HIV infection if the source of the needle-stick injury is from blood from someone who's either confirmed HIV positive or unknown status. This study that was done with doxycycline is doxycycline post-exposure prophylaxis for bacterial STIs only, right? So remember, doxycycline is an antibiotic that would treat gonorrhea, even though the resistance rates are high, so it's no longer considered optimum treatment. Can treat syphilis, right? We treat syphilis with doxycycline right now in Trinidad because we've more or less kept penicillin off of pregnant women. And we'll treat chlamydia, right? Be active against those 3 STIs. So the rationale was... You're
breaking up a little bit, Dr. Boyce.
So the rationale was, in someone who is, let's say, had unprotected sex, right? And who would come to use doxycycline to prevent STI acquisition, right? Just a second. Yeah.
So is it more because herpes is more viral as opposed to bacterial?
So herpes be treated by doxycycline at all, so it wouldn't be protective. So because it's not one of the things we would give prophylaxis against standard, right? So if let's say someone comes, let's say someone who has been sexually assaulted, right? We would prophylax against pregnancy, prophylax against chlamydia, against gonorrhea, HIV, sometimes hepatitis B, depending, but not herpes, because that's a bit. I don't think we have good evidence that doing that is beneficial. Plus, it's the risk of acquiring is slightly. Yeah.
I didn't get the latter part. But the risk of?
In terms of the risk of acquiring HSV, it's harder to quantify. Right?
Okay, I got you. All right. Thanks a lot.
Okay. So just a quick reminder to all the persons who have come and who are here. If you can't speak where you are, you can always type in chat box and we'll answer the question. All right. So let's pull up the case. In the meantime,